Thank you for an opportunity to speak to you this morning. Intel has been involved in aging research since the late 90s. It's sort of maybe an unusual area of research for Intel. Most of us think of us as a chip company, and essentially that's what we are. We are a silicon chip company. However, we do a lot of research in experience-led research with all kinds of people in different groups. But one of the founders of the company, Andy Grove, had a particular interest in this subject. And he felt that back in the late 90s that healthcare systems needed to change, and they needed to be more at home and in community, and not to take away from the acute setting of the hospital, because that was also needed. But he thought that not all of the care should be happening in the hospitals. And in some, going back in time, there was a time when going to the hospital was a luxury. Care came to your home, or your family took care of you. It happened at home and in community. And it was a luxury to go to the hospital. Now it happens in the hospital, and it's a luxury to have care at home. So in some ways, we need to kind of get back to the way it used to be. And so that's part of the rationale for Intel's interest in this. How can technology help to bring that about? One of the things that interest me in this area as we were looking at, like, Intel took the approach is largely looked at healthcare systems and managing healthcare, and Trill, which I'll talk to you about later, did a lot around the healthcare. But what struck me from taking a business perspective was a lot of older people are quite well. And a lot of older people are quite independent, they're quite robust, they're looking after themselves, they're looking after maybe peers, spouse, sibling, they're looking after kids, dependent older adults, they're looking after grandchildren, and they volunteer a lot in community. So, some of the stats that Roseanne spoke to earlier about, 1 in every child born now will probably live to 100 or older. What struck me was most of the people over 50, the over 60s, have most of the wealth in developed countries, Europe, US, and Japan. And what interests me as a woman too, women do 80% of the buying. So that's 80% of the females, have most of the assets, or have control over most of the assets in the developed world. And I'm like, well, gosh, why isn't anybody addressing that? Market research drops people from age 50. I just find it extraordinary that businesses are so ageist, my own company included. We spend all our time from a tech point of view looking at the 20-year-olds. And we're absolutely obsessed about the 20-year-olds. And we may stretch it out to folks in their 40s, maybe. But we certainly don't consider anyone from 50 to 80. And that debate goes on within our company, and that's why research on aging continues, but it remains in the labs rather than in core business. That is starting to change, but it's a slow change. In some of the work that we've done, as well as the work here in Ireland, we've also done a lot of work around Europe, large studies across Europe in 7 different European countries. And, most of the older people would say, no, the standard computing technology that you can buy doesn't meet my needs, doesn't address what I want to do with it. And, I'd spend a lot of time talking to our engineers saying, well, they'd say, older people won't use technology. And I'm like, well, they will. They have done all their lives. Most of the technological advances have happened in the last century. A lot of older people have used telephones, washing machines, cars, all sorts of things all through their lives. They will use them if it's designed for them. And their consumer, if it meets their needs, adds value, they'll buy it. If it doesn't add value, they won't buy it. Very simple. And still, we're obsessed with 20-year-olds. And by the way, most of the older people buy the stuff for the 20-year-olds, because 20-year-olds have no money. Right? So it comes back to who's controlling the money. And in business, in my view, you follow the path to money or you don't stay in business. Anyway, some years ago, back in 2007, we started Trill. St. James's is one of the partners in Trill. We have a clinic at St. James's. We were focusing, we worked with TCD, UCD, and mainly we were trying to understand aging, and independence, and what did that mean? And what did it mean from, a clinical perspective, like what was happening physically, emotionally, cognitively. And we wanted to understand how might you use technologies to assess early in community and intervene early. They were the principal premises on which we founded Trill. And we looked at the area of falls, cognition, and social connection. But Trill, I suppose, even though we are a technology company, it was very much grounded in understanding, clinically what's happening in the body, what's going on, and trying to understand it from that perspective. But also working with older people themselves and trying to understand it from their point of view. Trill is a large group of, most of the time up to 70 researchers, at sometimes a core strength of about 55. Within Intel researchers as well as the researchers at James's, TCD and UCD. And it was very much multidisciplinary. We had social scientists, ethnographies, a part of anthropology. We had physiotherapists, neuroscientists, geriatricians, nurses, engineers of all sorts, from software, hardware, firmware, computing scientists, just such a range of disciplines that came together with older people. We had, through the clinic, some of the things that we brought through, it was 630 volunteers in the first round, 400 in the second round, 132 in the third round. And all of these older people volunteered for these studies. They volunteered their time, they volunteered their information about themselves. We did all these medical assessments and tests. We advertised once at the beginning. We wondered, how do we get all these volunteers? They just spread the word between themselves. They got this, full comprehensive MOT for free. So there was some benefit to them, back to the consumer point. They got care if anything was awry with them, because they were in a hospital setting, so they were referred for care. So there was no issue about older people volunteering. We did a lot of studies in community as well. We worked with a range of NGOs and community social entrepreneurs, and through those they acted like the trusted advisors, so that we could work with older people in community, and not be a big corporation coming into somebody's home. Never, ever. So the whole sense of access with older people, working with older people, it's surprising, if you actually talk to them, they'll tell you exactly what they want. It's very simple. And part of our core premise is what we call design ethnography, also called, user-led or experience-led design. And, the principal tenet of that is you actually work with the person that you're trying to design the technology for, and that you involve them in iterations of the product design. This is, one case study where we were looking at attention training, and we wanted to know, what kind of technology would you need for a person to train themselves and improve their own attention at home, and that the provider that might help them get started would be at a distance, would speak to them on the phone, because we're working from the premise that there'll be less carers as we go forward. So we had to design the system, what would we need? And we started out with a laptop, and there were sensors attached, and there was people in the home, and it didn't work very well. There was too much technology. There was too many people in the person's home. And then we brought it down to, we just needed one sensor, for measuring skin response, skin conductance as a proxy for attention and alertness. And we brought it right down to just the sensor with a little screen, because we needed some kind of feedback mechanism to the person who was going through the protocol. And then we saw one of the next rounds of home experimentation. The volunteers put that little black box on the pink cushion, because it's too awkward to put on your lap. and then we designed it into a cushion, and then we got this at the end. We got a whole set of these, and that was the technology. And once the person learnt the protocol, understood the protocol, could feel the difference in themselves when they were alert, and had gone through that with the neuroscientists, in the end they didn't even need the technology. Could give back the cushion or give it to somebody else. So technology doesn't need to be complicated. A lot of it can be very simple and useful. Another one of the projects we looked at was around social isolation. We were starting with older people, trying to understand, how might they use conference calling. It's common technology used within business, but it wouldn't have been common, back in the day for today's older people. And we wondered, would older people get into a group session on a conference call, maybe with folks they hadn't met before? And we tried that out, and yeah, they did, if the topic was relevant. We did some studies around fear of falling. If there was a peer support group, a buddy system, clinically led, useful information, useful, how do you overcome your fear of falling, understanding that there's other people like you, how do you get over that, first steps towards going out the door, maybe just out to the end of the road, further steps, maybe going further down the end of the road or to the nearest shop. All the training that went with that, but it was informed. It wasn't random, it was informed, and you had a group, and it works. And these tools around conference calling, which is a group call, it's commonplace. It's not new technology. It's just a different person, consumer-oriented rather than business-oriented. All the features that we put on this phone, this is essentially a phone, all these features were designed in 3 rounds with different groups of older people. And one of them that really caught my imagination was the tea room. And obviously, older people, older Irish people who drink tea and have a chat over a cup of tea, hence became a tea room. The tea room was like a secured chat room on the internet, and you only invite the people that you know into that secure chat room. And you could register that you were available for a chat. And we kind of were like, well, why would you do that? You've got the phone, you've got your group. Why wouldn't you just call somebody? And then it came back to us, yeah, but what if I'm up at 2 o'clock in the morning? I can't just randomly ring somebody 2 o'clock in the morning. I'm caring for somebody who's got dementia. I'm now awake, I'm stressed, I need somebody to talk to. And that was the function of the tea room, which would never have occurred to us. So again, not new technology, just using what's there, listening to the people who wanted to use it in a way that was useful for them, and designing it in. And this study is more another one of the examples of, this had a more clinical route. It was a lot of work with a lot of people, both volunteers and different kinds of scientists, to create this. And this, right now, if you have a fall, one of the tests that you might be administered is a timed up and go test. But largely you have to get access to a clinic and very highly specialized staff. And we were trying to understand how would you make this more commonly available in community practice, and perhaps to community nurses and GPs who mightn't have the same comprehensive understanding of falls. But we needed to have sufficient information. So through a large body of study, we instrumented the timed up and go test with 2 sensors, one on each leg and one on the back. And we encapsulated that algorithm into an app which can be used on a phone or a tablet. And now a person in community, like a community nurse or GP, could administer that test. So we've taken it out of the hospital back to the community setting. And again, depending on what that test says, what's the reason that you might fall? You might get treated in community. It could be strength and balance training, it could be change of blood pressure medication, it could be different reasons, or it might be something more complicated and you do need a referral. But our imagination of this, that it could be taken out of the hospital into the community setting. And so the message that I'd leave you with, it is essential to co-design with and for older people. It's absolutely essential from tech companies' point of view. From a research point of view, you need to scale up and get out of the lab, move away from the bench, go out and do your experiments with older people in their settings and real-world contexts. And it is possible to avoid this scenario with good design. Thank you.